Yeah, we can see that now.
Okay, so
it's still in the not in the full presentation mode.
Okay. It's okay. It just really, the slides are really just a little bit of basic stuff to guide us. And I'm going to jump between slides and echo on a little case that was interesting we did recently. It was sort of joint case where Neil and I worked, actually, because he was on in the unit overnights and I came in during we messaged each other, and then I came in the morning to just look at a few things that were of interest to me. So I'm going to do my best to jump between background and some images. I simply haven't had time to clean all the images, so we'll just run through them and comments will all be welcome. So the background to this little case is that we had a little extremely preterm infant born, extremely low birth weight. This baby had actually quite nice antenatal optimization in terms of antenatal steroids and mag sulfate, and a nice stabilization in labour ward, which would be our approach for these wee ones, intubation and surfactant. Came upstairs nice and warm, was on synchronized modes of ventilation with volume guarantee, initially in air. Over the first 12 hours of life, the baby commenced a bit of dopamine, 10 mics per kilo per minute for a borderline blood pressure. But again, also over those 12 hours, she had an increasing oxygen requirement from air up towards 60%. So she had a first hemodynamic assessment. That was done around 14 hours of age. And when we look at babies now, we're sort of trying to look at the global situation, their background and their other parameters, because echo is just part of the whole assessment. So managing on volume guarantee, ventilation, tidal volumes of 6 mils per kilo, using pressures of about 20. Blood pressure means 21 to 24, though interestingly, systolic quite high, diastolic maybe drifting a bit. It's hard to say, but these unfortunately were non-invasive blood pressures, so we might just have to take them with a pinch of salt. Nice hemoglobin, as it mentioned, was in about 60% oxygen and had satisfactory blood gases, and a lactate of about 2 was the only thing that was maybe just not quite ideal. So what I'm going to do now is switch screens. I'm going to stop sharing this one. I'm going to share the other one so I can show you the echo images. Right. Can you see that screen?
Yeah.
Okay. So I'm just going to run through these images because I just haven't had time to clean them all. But I think the first sort of thoughts were that we've got a reasonably well-filled heart. There are some subjective impressions here about the right ventricle maybe being slightly dilated for a little bit of septal displacement. And that was Neil's early concern. And he certainly found that he felt that the S prime volumes were a bit reduced. But again, you know, it's difficult because this is a very preterm baby. Septal and LV difficult to capture there. But these volumes certainly, these velocities, certainly the S and the E are low if you compare them to term babies. Interestingly, they might fit into their standard range for very preterm babies, but what does that mean? Just to go on and look though, when you put the colour Doppler on, it's now very clear that there is significant tricuspid regurgitation. And I think as we go on, maybe the more you look at that RV, you feel it's just not working as well as it might. So there's your tricuspid regurgitation up to 3 meters per second. And this is just looking at the E-wave across the tricuspid valve, which will just summarise things. And now we're just having a look at the LV, and perhaps nothing terribly exciting happening at the LV at this point. You do get the impression there's a little bit of MR that wasn't immediately obvious on the colour, but the velocities across the mitral valve are not elevated in the way that we might see if we were really worried about a big ductal shunt at that point. And now we're just looking across the pulmonary valve, and you can probably just about get the impression we're going to find something ductily that might be a bit bidirectional. Here's the sort of pulmonary, going a lot across the pulmonary valve. So there's sort of quite rapid acceleration there. And then just going down sort of views, I don't think we ultimately did global strain measurements in this, but I know Neil's interest at this point was just wondering, you know, how well is that RV working? And if anybody wants to pause and look at any of those views for longer, highlight anything, please feel free. But then just coming on now to the arch, looks fine there and unobstructed. Coming on down though, there is a hint, I think, if you try and get down to descending aorta, there's not much antegrade flow there. And now when we've got the ductal view, you've got this interesting thing going on that you've got, you can clearly see your right and left pulmonary arteries, and this is the ductal view. And although there's flashes of red blood flow, it's predominantly right to left. And if you put the Doppler into that, you've got sort of 2/3 really right to left. And one option actually you can do is calculate out the VTIs in these. I'm not sure yet how useful it is. I think Neil's found that useful when understanding the degree of right to left shunts and pulmonary hypertension babies generally. But certainly without the VTIs, you can certainly see there's a predominantly right to left shunt, but not exclusively. Enough to say, I think you've got suprasystemic pulmonary pressures. Just another view of that there. I think that's possibly just trying to capture the ductal waveform there, I'm not sure. And this is going to be looking at times to ejection and pulmonary artery acceleration, which we'll come back to maybe. I'm not quite sure what I've captured there. So interesting pictures there. And I'll just, if I go back to my talk, I can kind of summarize what we found. But anyone, any comments, first of all? This little baby, 14 hours of age, hadn't been in much ventilation support, increasing FiO2 requirements. Any thoughts or any images people would like to look at again?
Can I ask a question, please?
Yes, of course.
It's quite interesting to see they started dopamine as the first line. So yeah. What was the kind of rationale for that?
Well, the dopamine had been started before this kind of hemodynamic assessment over the course of the day. And I think it was because the baby's blood pressure drifted down to about 20, 22. Mm-hmm. And that's still very much a first response inotrope for low blood pressure. It possibly did bring it up slightly. There could be, you're obviously thinking, Mahmood, we've got evidence of pulmonary hypertension, but I suppose, and dopamine could make that worse, but there could also be multiple pathologies going on here.
Yeah, I'm sure you're going to speak about phenotypes at the end, so I'll just leave you to do that.
Well, not necessarily. It would be good to have that discussion if we've got time, but let's see, this is just very quickly pulled together. Okay, so thanks. If I...
Anne Marie, can
hi.
Slide, sorry, Vikas here. Did you show the I just want to see what the flow around the PFO was. Was it all left to right or?
Oh, PFO, I can't remember. Let's see. I don't know if it's actually a Doppler of the PFO.
See that? Did you have a Doppler?
I mean, there you go. So it's looking here like it's certainly bowing right to left, doesn't it? I don't know if there's a color Doppler.
All right.
But you can see that there, and it's a very good point. And yeah, you're just about catching it there, but maybe not quite. But I think it's interesting because I don't know if I looked at that initially, that without maybe paying attention to this, which is a really good question, I don't know if I'd quite have anticipated that's what I was going to find in terms of TR. And one of the things I'm interested to hear what other people find is I find there's an awful lot of unexpected, unanticipated MR and TR in these small preterm babies when we look at them. And I think that is one of the things that is worth talking about, because, you know, if we look at what's going on with their myocardial contraction and movement, if you look at the tissue Dopplers, the velocities that they can achieve are very low. And I think, you know, you might say these are normal for 23 weeks when we look at them, but is that adequate? Is that heart just going to struggle to cope with any antegrade pressure, pulmonary vascular resistance or systemic vascular resistance on the left side, or volume loading, and just result in a system that immediately has valvular regurgitation and knock-on effects from that? So I think there's a message here that, for me, is that these little myocardiums just don't cope with additional pressures.
Sujas, you've got a question?
Yeah, Anne Marie, can I ask a couple of things? So was there a pre-postductal difference, and what dose of dopamine is the baby on?
So the baby, I think, was on 10 of dopamine, and I don't think anyone had looked for a pre and postductal difference.
Okay.
So there wasn't necessarily an expectation that this is what would have been found. Yeah. I guess we had a look because someone was on for real interest in hemodynamics, was on for the night. I don't know if someone else had come on, if they might have said clinically, this baby's FiO2's up, let me look at pre and postductal differences. It's a good point, and there's lots of ways of looking at this. But I do think what you find with this sort of regurgitation is just something that you don't necessarily anticipate from all the other clinical parameters that you're going to be able to look at.
Yeah. No, thank you.
That, as we'll come to, I suppose there are other sort of pathophysiologies at play here that we shouldn't ignore, and I'm sure the clinical team, whether or not they echoed or not, would consider. So I'm just going to stop sharing that, and I'll share my other one.
Maha, do you have a question?
Please go ahead while I'm busy sharing.
Thanks. Anne Marie, I was just wondering, did the chest x-ray look awful? I mean, did this baby have really bad lungs? Was that one of the reasons for the...
That's a really good question. It's a really good question. It's one of the things I was thinking actually just before I joined you, and I didn't quite have time to pull up, and I will for the future. We know that she'd surfactant in labour ward and initially did really nicely, but we are now 12 hours on. So I think the big important question is, yes, you know, what is the respiratory physiology, isn't it? So if I just move on and just summarise what I guess we'd found, and then summarise the actions, that might sort of bring it all together. So there's very much a dilated RV with impaired right ventricular function, if you put it to compare it with normal term standards. There's certainly evidence of elevated pulmonary pressures. So TR3 meters per second, pulmonary pressures estimated about 40, excuse the typo there. For those of you who are interested in pulmonary acceleration times and ejection times, that ratio is abnormally low in keeping with significant pulmonary hypertension. There is a duct. Now, Neil thought it was about 1.2 millimeters. I think it was difficult to capture the duct diameter in those views that we have, and difficult if you've got predominantly right to left shunt. The point being, it hadn't closed. It's a bidirectional shunt, predominantly right, which just adds to the overall picture. I'm just going to close the door behind me in a moment to cut down some of the background noise. But we had a predominantly pulmonary hypertension phenotype. And the response was, yes, let's give another dose of surfactant. Let's consider lung pathologies, and an X-ray would be nice, to try and reduce the dopamine and consider adding dobutamine. Neil and I had a little chat and agreed that I would have a look at things in the morning. And I looked at the pictures in the morning, and I just kind of highlighted the concern. I thought that duct might be more significant potentially than anticipated, and that we should certainly follow things up closely because things can change very quickly. We suggested adding NIRS. I can't remember if we did the first day or the first morning or not. I'll come back to that later. So 2 seconds while I nip and shut the door. So I suppose just before I go on, you know, to nip back, does anyone disagree with that sort of assessment and management?
Hi, Anne Marie. I think that's probably what I would have started on, to be honest, what you suggested after the hemodynamic assessment, because we know those babies, the most common phenotype is just very high SVR and poor adaptation and transition. And probably dopamine made things worse in terms of increasing SVR, increasing PVR, and making the myocardium even struggle more. And I wonder if there is also a degree of LV dysfunction or only RV dysfunction as well.
Yeah, I think there may have been. I think it's quite possible. And you're right, it just kind of reinforces dopamine not great for these babies. I mean, I think some of the pulmonary hypertension we're seeing is definitely related to typical pulmonary pathophysiology with a degree of RDS, because the baby, certainly I can say that the FiO2 came down nicely with the surfactant. So you might argue, most people, well, if you weren't echoing, that's what you'd be doing anyway. So I can see that, but I think we've uncovered an RV that really doesn't cope with that, which is interesting to know. And you've hinted at possibly an LV that's not very happy. And we're aware that there's a duct there, and we're giving surfactant that might have big changes in pulmonary physiology and needs to be reviewed. So
I think Maha has a question. Sorry.
Yes, go ahead.
I'm sorry, Mahmoud. I think you said what I was about to ask about the dopamine, because we've certainly sort of gone away from dopamine because it is mainly a vasopressor, really, isn't it? So I'm assuming that it may have helped a little bit of the SVR, PVR go up and the baby's cardiac function reduce a bit. But do you ever start with adrenaline? Because that's what we've started doing when the numbers are, as you say, if you chase the numbers, you're going to think you have to do something. And so we've been starting with adrenaline, which obviously is a much better, well, it is an inotrope, whereas dopamine probably isn't at all an inotrope, isn't it? So I was just wondering whether that was anything that you considered as well.
So personally, yes. Obviously, we're working in quite a big team, and I'd be interested in how other units get on, but we still have, there is very much, people feel safe and comfortable going with dopamine as their first go-to drug. As you say, it's a pressor really, and it can also worsen pulmonary hypertension. It did possibly give the desired response of bringing up the blood pressure a bit, and maybe that did slightly help balance the circulation slightly from a purest pulmonary hypertension point of view, but it has so many other potential adverse effects that I'm just not keen. So our recommendation is preferably people start low dose adrenaline, or adrenaline and dobutamine, or if they're scared to start adrenaline, at least start with dobutamine, and as the blood pressure sags, add in adrenaline. So that's kind of what we're trying to do, but it's quite a difficult cultural shift, I think. And it takes people outside their
saying
comfort
that,
zone.
because it's reassuring that it isn't just difficult with some of us. Yeah, wonderful.
Yeah.
Hi,
And I suppose,
guys.
sorry, someone else talking.
Hi, Zoltan's here from Oxford. So our first approach is dopamine, if it is the blood pressure only for very preterms. And then we can dedicate a separate meeting or a separate talk for that. Why we finally ended up with, if the blood pressure you are chasing, then I think dopamine is okay. Obviously, if you are chasing systemic flow and other thing, but then you have to screen for that and you have to monitor that. I'm just in terms of dopamine and who starts with dopamine these days for preterms, but we can dedicate that at a different talk.
Yeah, and I think it highlights, you could argue lowish blood pressure, someone might think pulmonary pressure might be like, let's start dopamine, and you could argue that they have improved BP if that's what you're chasing. But I think this just shows what you gain by having a look at what's actually going on, and coming up with a sort of pathophysiology based approach that understands what's actually going on.
After an echo, I think it's easier to see clearly.
Yeah,
if it's only the blood pressure what you have, and the preterm baby box standard RDS blood pressure is low. I used to work in a unit when we introduced dobutamine. It didn't work, and I'm happy to share my experience with that, why it didn't work. So if you change the blood pressure and you start dobutamine, sometimes the baby just goes tachycardic, the blood pressure won't improve, and then the pool register will be there. What shall I do? The blood pressure is still low. So either
that's
you
very
can
interesting,
and you go
because
for flow, systemic flow, then it's fine. But then if you don't monitor the systemic flow, you don't screen for the systemic flow, just because the pathophysiology is there, then you should kind of start them all on dobutamine, right? So it's difficult when you chase the blood pressure and you start a drug which is less effective than dopamine, and then the poor registrar is just, you know, in this limbo all night that, oh, why the blood pressure is improving.
I agree, dobutamine can be challenging and it can just result in tachycardia, and it's not a perfect drug either. We know can improve flow slightly. It doesn't help if you're chasing the blood pressure. Can I ask, so do any of the units automatically start with adrenaline if they have got either a slightly low blood pressure or a flow issue?
So we considered putting adrenaline. So I reviewed our guideline, and we were considering starting with adrenaline. The problem is that with adrenaline, you will have a few babies who start shooting up the lactate, and it is just really difficult to see clearly. Is it down to the adrenaline, or is it down to the babies getting poorer and the systemic perfusion is poor? So finally, after long consideration, we agreed on using low dose dopamine. So low dose, which means 10 or below.
Okay.
So like pumping up to 20 or 15.
Interesting. Yeah.
But we can dedicate one session to that. I'm happy to bring a case and then we discuss. Okay, so it's a kind of very easy case. And then...
Okay, so moving.
Sorry, Anne Marie. I think Neil has a hand up.
Oh, Neil. Okay, sorry, I just can't see the screen of everyone. Please go ahead.
No, sorry, guys, and I was a little bit late joining, but I'm really glad that you're presenting this case, Anne Marie, because I know we both know it well. And it was just a brief comment. I think Zoltan actually just touched on it there, which is it's not just about the agents, it's about the dosing, isn't it? And some of the effects that we want are probably achieved at different dosing than might have been used historically. And I think around the hopefully the kind of ongoing appreciation of the potential role of adrenaline, including in these very preterm babies. There's something about a shift in the mindset from the old high dose adrenaline dosing that people have traditionally maybe used in term respiratory hypoxic respiratory failure and severe hypotension and sepsis and things, to actually a much more nuanced use of lower dose. And the same goes probably for dopamine, dobutamine as well.
I'm glad you said that, Neil.
Sorry, Anne Marie.
No, I'm really glad you said that, because there is a big difference in the effect of adrenaline. It's sort of low dose and higher doses. And I think that is one of the pitfalls if people introduce it in the right nuance where you will get a lot of adverse effects and then it puts everyone off. So it is about getting that approach right, because actually I think for our small preterm babies, I think it can both, can be beneficial both in sort of slightly reducing that very abnormally high SVR and helping with cardiac function. So I think in the right way, I think it can be very useful. I'm still not got a feel yet for how it interplays with low dose dobutamine and whether or not we can get away with that, or if that's a good combination. So that's the first echo and outcomes. And then there was a second hemodynamic assessment that night, about 36 hours of age. And you were there at this point, so please tell me if there's anything about this that isn't right. So the baby's FiO2 had improved, come down from about 60% to about 30%. So there's probably been a surfactant response, still in modest pressures, still ventilated. No plans to actively push towards extubation, because we do tend to have a feeling with these very small babies that we've moved away from very early extubation. Or I think we're moving away, maybe not quite black and white. The dopamine had been reduced, which was good. The baby hadn't started dobutamine, but that's okay. The non-invasive blood pressure means were better than it had been the previous night. And I'm not sure if that was a good or a bad thing, but we'll come to that. The lactates had gone up 4 to 5, which was a concern, and a bit of a base excess, but the PCO2 would again reflect it wasn't respiratory. And there may have been a metabolic component. This baby now had high sugars and other things going on, so we have to be open-minded, but that change in the lactate was concerning. And as Neil and I discussed the previous night, it'd be good to have a look again 24 hours later and see what's going on. So we went to the second echo, and I'll just move to the pictures, I think, before I give you the slide that tells you what happened, because that'd be a bit of a spoiler. So stop sharing this one. Go back to the other screen. And I'm just going to have to change echo. So you'll see me just swap over to the next scan. Fortunately, I think these are all nice and sequential. So, and I'm just going to run through them, and I haven't looked at these recently, I just haven't had time, so I'm just going to have to sort of see what I think we're seeing as we go on. The striking difference now is that first echo, isn't it, that there's a big LV. Yeah, I'm still not sure how brilliantly that RV is functioning, but there is a big, it's a hyperdynamic looking heart. There's a big LV, and that is maybe not clear there, but I don't think that PFO is now going right to left. Neil was obviously struck by that, and he then went on to look at TAPSE. I don't know if you looked at MAPSE next. Nope, TAPSE. So I don't know if you want to comment on that. It's not something I remember looking at in particular detail at the time. Then went on to just put the colour Doppler back on. So still got TR there. So this RV, even though the pulmonary, even though given surfactant and the baby's oxygenating and the lung pathology seems better, still not quite happy. Doesn't look like there's difficult to capture, but between the different inflows and outflows, but doesn't look like there's much going on at PFO level. And just capturing that velocity, it's still quite high. It's maybe the jet isn't as broad as it was, but the velocities are still up to 3 meters per second. Just there, and actually I think you're maybe capturing there some of the pulmonary, sorry, using my finger, not my pointer, pulmonary venous inflow there to the left atrium, looks brisk. Just going across the tricuspid valve, the velocities aren't huge there. Now looking at the left side of the Doppler on, and suddenly we're seeing this mitral regurgitation start to come into the picture. I suspect that's looking across the mitral valve, and you're seeing increased velocities now in inflow and EA equivalents, which suggests volume loading. And you're capturing a bit of this mitral regurgitation here. And I think here Neil's picked up in one of these pulmonary veins coming in. And the reason that, you know, I'm saying that is it's just so obvious, it's just striking, isn't it, that you've got really increased pulmonary blood flow there. And just putting the Dopplers into that, the D wave velocity is right up. So that's a very abnormally brisk pulmonary venous return, which of course is suggesting that you've got very increased pulmonary blood flow. More of that, just convincing himself, I think, that that is indeed extremely elevated. And then just going on to the pulmonary outflow, you can see here now, nice pulmonary valve, pulmonary arteries, bifurcation. Question is what's happening at the duct, which you can't quite see in that previous picture, but just looking across the pulmonary valve there, it looks like there's very turbulent flow consistent with ductal physiology, and there you can see the duct. And it's now perhaps looking like a much fatter, juicier thing than had been apparent the night before. So as the flows change, you know, this vessel, I think, can stretch up and look much larger. So a big duct, which an eyeball looks like it's all left to right, may not be quite continuously, but it's certainly unconstricting down its course. So a nice view there going down the ductal course. And now Doppler's in there, and you have got a pulsatile waveform with overall low velocities and diastole. So this has now become a very low resistance left to right shunt down the duct. Just confirming that. And Neil, if there's anything you want to say as I go through these pictures, just shout out.
No, thanks, Anne Marie. No, I think exactly as you're pointing out, what really struck me and was how the physiology had changed here, and I was really surprised at how prominent this kind of ductal physiology was, and enlargement of the left heart, as you point out there, the increase in pulmonary blood flow. And it was interesting, you kind of predicted it when we were spoken the day before, and I was really amazed at how quickly the phenotype had changed here. And then I think a little bit concerned, as I'm sure you're going to talk about what the risks of this physiology were as well.
Is only at this stage, I think. 36 hours. So we don't typically, our practice has been, my practice has been, I go in and look at assertive ducti on our babies under 28 weeks. I have tended in the past, though I've had reason to change recently on the smaller babies, but I've tended to say, well, let's just see what's happening around 3 to 5 days. And if it's moderate to large, then think about medical treatment. So I think now you've managed again, and just again, you were just looking at this and thinking, well, here, we've got this much more pulsatile actually with lower diastolic velocities as time goes by, which is something you often see as you look at these. They seem to grow. I've sometimes seen the LV grow and shrink and grow as you look at them. And you've got 1.2 millimeters there. I haven't measured it, Neil. I think I could possibly, I've got that to be bigger, but it's not really the point, because I think too much is made of duct size. Because actually, measuring a duct, which is a complex 3D structure, is actually really difficult, and it's much more about what's going on with the other parts of the physiology that tell you about the shunt. You've looked there at LAA ratio, and it is indeed increased. It's sort of, I think you got about 2 to 2.2. And I'd gone on and just taking measures so we can look at fractional shortening. I think the striking thing is these measures, and I think looking at the LV as you went down at circumference didn't look too bad, but I don't know if you looked at it in this echo. I did look at tissue Doppler subsequently. The tissue Doppler measures are low, and again, low, well, normal for very preterm possibly, but is that giving that myocardium adequate reserve to cope with what is now an increased volume load? Because we see this babies, if you consider, does the LV look happy? Maybe, but is having torrential MR an appropriate physiological response to volume loading? It's not. And does that have knock-on effects that we'll just come to talk about in a minute? So there's that duct again. Now you're looking, I think, down the left pulmonary artery, and we've got this really marked increase in pulmonary blood flow and diastole. And it varies a bit in terms of when you measure it, and this is something I'd be interested in people's thoughts. Do you measure the maximum in diastole, the minimum? The VTI might be useful, but we often talk about velocities here. And 0.5 is a cutoff for large, and I think that baby makes that. More of that. You've worked out the LA ratio here, 2.15. So there is some increase, but it's not massive. And again, I think that is interesting, because I just don't know how well that LA can actually dilate. I think that is one of the issues sort of very early on, how well it's delayed. Because now look at this LV, and I'm looking at that and thinking, oh my goodness, are we in trouble? Yeah, so you have gone on and looked at Dopplers. So again, to the right, I think those systolic velocities are better than they were before. Septum, probably not as good as you see in term babies, Neil. I'm not sure that I can interpret too much on that. But then go over to the LV. It's difficult, but that's really quite a low systolic velocity. And if you can tease out those unique waves, they're really quite, I think, maybe depressed isn't the right word, but they're quite low.
Yeah. Yeah, I was a bit surprised at those, and it may be partly the angle of intonation, but there's quite a prominent early diastolic wave, which I think fits possibly with the response to that increased
interesting
pulmonary venous flow as well. Yeah. But I agree. Overall, I was surprised that the velocities were a little bit higher there. I'm not quite sure what to make of that, because when we've looked in a population of babies with patent ductus before, admittedly it was 10 years ago, we saw kind of normal velocities. Now, whether they were normal for a baby with a big volume loaded heart, I think is another question. But so I'm in my own head still not quite sure how to interpret velocities, but I agree, maybe the function is certainly systolic velocities there are lower than I would have anticipated. Yeah.
Anne Marie, Anaya has a question.
Yes, go ahead.
Oh, this is fascinating. In terms of the mechanism of the pulmonary hypertension that you saw, do you think it was flow driven because of overcirculation, or you think it was LA being dilated hypertension leading to pulmonary venous hypertension, leading to what you saw on TRJ?
So I think that the early pulmonary hypertension was probably related to RDS. Someone asked if we'd had an X-ray early on. I think, you know, had I a bit more time to put this together, I imagine I'd put up an X-ray that possibly looked like there was RDS. So I think that was part of it. I think what I do worry about is progressing, that we get pulmonary venous hypertension coming into play. The RV is still not quite happy. The LV is very unhappy. It is volume loaded, and I do wonder, because we have this myocardium that can't relax very well or stretch very well, that actually immediately puts a back pressure onto the pulmonary vein. So I think we've changed pathology quite quickly. You know, it's never absolutely all one or the other, but I think it's been quite a shift. And you can just see that sort of septum looks slightly unusual with the volume there, I think. And then just looking out through the left ventricular outflow, it is brisk, but that just allows us to come back and work out the outputs. You can see there is antegrade flow in the SMA, but it's maybe just falling off, and confirmed by Doppler, it drops out at times, if not quite reversed. It's variable. Nice pictures to have. You can sort of see there a wee flash of blue coming in now and again, I think. So, and it does, difficult, I think, to measure the angle of what's going on with the descending aorta, but it looks like it might be dropping off higher up. Sorry, making a moment to load. Oops, I'll stop harassing it. No. I'm going to have to reopen Echo Packs. Goodness. Really didn't like something I did there. So, I mean, I suppose what you guys, while this loads up, can predict is what my next slide might show if I just share my different screen. I can try sharing this one now.
Just while you're doing that, Anne Marie, just one comment that I'll make, I don't know if it's of interest to people, is how long these echoes took. Clearly, there are quite a lot of images that I took there in that one and in the previous echo, but when I looked at how long it took me, I think the first echo was around 5 to 8 minutes. I can't remember exactly what, and similar for the second one. And I think sometimes one of the concerns is that these echoes require a lot of handling of the babies and a lot of time. I'm interested in what others use and what's an acceptable amount of time. But my experience was taking both those echoes, it was quite short, and the clinical status of the baby didn't change throughout.
Yeah, that's good. Yeah. I think, Neil, you are particularly slick at doing these, but it is true that generally I find the babies are quite comfortable. And it is, the more, there's no doubt, the more you do, the sort of much slicker you get at doing it, and you can do it quite quickly. But I generally find them quite comfortable. Biggest problem is that they might get slightly cool, and we just have to be very aware of that and stop as they are. So the second echo, just in summary, the RV was less dilated, but there is still some RV dysfunction. And Neil measured a duct of 1.4 millimeters, which isn't huge, but there was really increased pulmonary venous flow and reversed flow in the descending aorta, and abnormal flows down in the SMA. And if you put all together those bits in an Iowa, not an iOS score, but an Iowa score, it comes out at 8. So the Iowa score, I'll show you next bit, looks at the mitral inflow, IVRT, LAO, I think, LVO, flow reversals, and pulmonary venous flow, which you can kind of intersperse. You could probably substitute with left pulmonary artery flow if you struggle to get it. So they recommend, and the Iowa team will go and treat ducts when they reach over 6. And this one is a score of 8. I did try to calculate out, did this baby have an increased SVR, just using the blood pressure, and it's not times, it's divided by the LVO, so apologies for that. And we've got 188, which is in the higher range of normal, but you've got a big duct, so I just think it's really difficult to know what that means. But I do wonder if this LV is trying to cope with a load it can't and an increased SVR, because the baby's blood pressure wasn't low despite this big duct. So I think Neil, did you not have a bit of a chat at that point in time? It was evening, but an acceptable hour. And we both thought this baby was at risk, this significant risk of pulmonary hemorrhage and possibly secondary IVH. We decided overnight, because it's tricky to make huge decisions overnight, but also first things first, maintain the PEEP, try and get rid of the dopamine and go on to dobutamine. Ensure, just in terms of protecting our organs. Now, I often do this if I'm thinking about giving ibuprofen the next day, make sure that there's a decent hemoglobin and that there's some maternal milking in to protect the gut, with a view to starting at ibuprofen the following morning. And I plan to come in the next morning and chat to the daytime consultants, who typically in our service have more of a say on the sort of direction of management if things aren't acute emergencies. So that's how we did it. And just, if you're not familiar with the Iowa score, that's what it looks like. It's quite nice because it doesn't include a duct diameter. I think its weakness is it doesn't have mitral regurgitation in it. And I'm always a wee bit anxious about things that are cut-off point based, because sometimes you can feel in another couple of hours we'll be there, but if I write it's below a treatment threshold, people might not be happy. But essentially, I think it's quite nice. So, any comments on that before I go on?
Hi, Anne Marie. If I can just say a small comment about the striking actually change in pathophysiology within just overnight after the surfactant, as you already alluded in the first presentation. So I think that really highlights the importance of continuous monitoring of those babies' hemodynamics. And with regards to the duct size, although it's 1.4, but the baby is only 23 weaker. So that might be significant for this particular baby.
I think if we maybe I don't know, it just goes off us. I don't know if I measured it the next day or not, but it just goes to show the limitations, doesn't it, of a duct diameter per se as a sort of single marker. So I'd be curious, the rest of the group out there, would anyone else be thinking in their practice, in their unit, would they be aiming to treat this duct?
I wouldn't have probably treated, but it's just to do with the culture of the unit and the way we have moved over the last 5 years. In our unit, in the last 2 years, we've not treated a single duct. And sorry.
That's really interesting, because we've treated quite a lot. We've had a few we haven't treated, and I've regretted because I've had massive pulmonary hemorrhages not long afterwards. But I wonder, you know, does that reflect anyone else's experience?
It's quite interesting what Anna has commented. Probably, in my experience, it has moved more in towards a favor of treating drugs with the amount of secondary complications we have seen recently. And recently, in last 6 months, I have seen at least 2 to 3 babies who had significant kidney hit, with creatinine rising at as high as 180s, 190s, with reverse end-diastolic flow. And as soon as you treat the duct, get duct out of the equation, the kidney functions normalized. So, I've seen, the practice swinging towards treatment.
And I think the problem is, once you get into that renal impairment or neck type pathophysiology, if you believe in that connection, it gets very difficult to treat it. So you get a bit stuck. And I don't know, I think I've seen enough of babies untreated struggling to make me feel that it's reasonable if they're large. And we've certainly seen, maybe for lots of reasons, and I'm scared to say it too quickly, but sequentially year after year, our neck rates, as we've done this, we've been down and down and down. So I'm encouraged. But
absolutely, as you said. So we looked at this in terms of acute outcomes, just objectively to try and see whether it has changed. So as you said, over the years, NECs come down despite us not treating. The BPD rates have come down despite not treating. ROPs have come down despite not treating. So, I mean, obviously, these are all, clinical outcomes are multifactorial, and it's quite difficult to just link with one intervention as inductive treatment. But that's an issue, I think, just demonstrating a change on a longer-term clinical outcome.
Just a comment in types of the sizing of the duct, particularly in 20 to 23 weekers, as we have more and more of this now we are looking after 22-week 2. So what I do is also, and I'm sure other people are doing it also, is to compare the size with the LPA. So LPA has got Z scoring with the weight. And if you go to weight only criteria for LPA, you can Z score because it's widely used in fetal medicine. And so the fetal medicine has got a Z score till very extreme gestation age. So though it cannot be exactly reproducible in terms of how you measure Z scores in fetal medicine as well as post-satellite, that can be argued. But if you use your end systolic measurements, write it, put your ECG leads, write it at the T waves junctions, and you measure both the Z scores, see that the LPA is not, just to rule out LPA stenosis. And then if the duct size is similar to LPA, then I would say it's significant in terms of sizing. Then that's one way of whether you treat it or not is a different thing, but that will give you an idea where your where your duct is.
I think that's a really good comment, actually. Something I've thought about in the past and haven't done recently, and I think that's really useful. So
I think just one comment about the ductal size. We did hear a prospective intra-observer variability study where 2 people who scanned saw each other scan blinded, and what we observed was difference of 0.8 millimeter was purely by chance. And hence I, in my clinical practice, don't use at all ductal diameter.
Yeah, I suspect I've looked at an awful lot of ducts, and I suspect I've got a fairly consistent way of looking at them without realizing, actually. And I think my measurements would have been different from Neil's. But actually, I think, the comments that A, it changes, B, there's intra-observer variability. And I think the importance, is however you do it, whether it's the Iowa score or a much more descriptive score with other things in it, I think and it might or might not include the duct. I think the key is looking at the global pathophysiology and the degree of systemic shunt and the impact it's having on potentially on other organs. So, yeah, I think we're all agreed in that.
Just in terms of any cardiac structure, as mentioned, and as mentioned, any cardiac structure would have both inter and intra-observed variability. But if you measure it, particularly you can minimize this intra-observed variability by ensuring that babies are connected to the ECG probes and measuring it the right, rather than the valve opening and closing. If you measure it rightly on the ECG trace, I've seen that you can minimize the variability. Again, it's not 100% accurate, but this is what you have at the moment, the technology.
That's interesting. Did you measure it at end systole or?
Yes, end systolic. So all the cardiac blood vessels measurements, whether it is LVOT, RVOTs or aortic sizes, where I measure aortic isthmus or for coactation, or always measure it end systolic on the ECG rather than on the, and I've seen that this minimizes my inter-observability.
That's a really good tip to have. Okay, excellent. So I looked at the baby in the morning. It was now about 40 hours of age. Ventilation was stable. Blood pressure looked okay, but again, it is non-invasive, so we'll maybe take it with a slight pinch of salt. It's hard to say. The FI2 was stable. We'd put on cerebral nerves, and we were getting just around, for us, for our probe that we were using, getting just above the hypoxic threshold. And possibly with the interventions overnight, maybe going to butamine, which started, the lactate was now 2. So something had got a little bit better in that sense, which was good. What have we done next? Echo assessment. Right, I'll switch screens and show you the echo. And again, I apologize because I haven't looked at these echoes since I've done them. So I hope all slightly anxious of what I'm going to find. Here we go. Now, are you seeing echo or not?
Not yet.
Not yet, okay. Yep, got it now?
Yeah, all good.
Okay, so just starting subcostally and just really finding my orientation. So there we've got the SMA, and actually we've managed to maintain some flow, which is interesting. Reasonably full IVC. So I think the baby's reasonably well filled, which has been one of the issues with high sugars, etc. But now if we look, we've got that PFO and it's going left to right. Still a little bit of TR there, But you can just see coming into the picture, I think there's a lot of MR, which is interesting. Different scale on from when Neil looked at these overnight, but just capturing that pulmonary vein, and we've still got a very high D-wave flow. Even I'm not quite sure what I was looking at there. I might have been getting a bit of SVC, looking at SVC just to see what was going on potentially, but I think I struggled to get the SVC diameter later, so I didn't bother. Little bit of TR still persistent there. Sorry, just there. And just looking at the tricuspid valve, and then coming over to the left side, here you can see now there's this huge big LV with really quite significant looking MR in terms of how broad that is. And you can see the velocities here now up to 2 meters per second, which I think is significant. You get some spillover across diastole. I was just trying to get the best view of it, I think. There you see it there. So, you know, that's, to me, that's pretty significant. And I think I was struggling just to believe it and to try, I think I was struggling to try and capture it well, to be honest. So again, we're just looking at this LV, and you can see, and it's a sort of slightly modified parasternal long axis. It's really dilated. And you can see on that view, you can see the MR there. And there, I think sort of captures it, just kind of moved around more to a sort of almost a kind of 2-chamber view. I was trying to be quick because I think people were beginning to think this baby's been echoed quite a lot, and I think we knew what our pathology was. So I just came up a bit and looked. Yeah, I'd obviously thought about looking at SVC flow. Don't know that I did ever calculate this out. Let's look at the left side there. You can just see that regurgitation there. And now we've got an LA-AO ratio, which I think I did calculate out later. I need to see if it's at the bottom, but you can see now that actual left atrium is beginning to look quite big there. So that's changing. Just looking at the ascending aorta. So I'm just working around things basically, looking at the flow across the pulmonary valve, which is consistent with a duct, and then I think getting down to the left pulmonary artery, and we've still got this very elevated pulmonary blood flow there. And in the duct, we've got, again, these aren't perfect pictures, but we've got this very pulsatile left to right flow pattern. Pulmonary vein, again, now that flow is much higher. And again, just trying to look at the sort of tissue Dopplers. The S prime is probably improved from day one, but just looking at the left side, that is still seems low. And, you know, it is the debate, is it the effect of the loading on the LV, or is it showing us we've got an LV that just can't cope with loading? And that's why we've got the really striking regurgitation, which you don't typically see in bigger babies with ducts unless they're really in extreme clinical heart failure. Again, just showing you that dilation and the ductal pattern again in different ways. So now just looking at the left ventricular output. So I did a relatively quick study which kind of confirmed what we knew, and but actually I think it looked even more dramatic. And yeah, was just able to say to the team, look, you've got very much left ventricle, not LVA, and duct physiology with very significant MR, and that really does worry me about the risk of pulmonary venous hypertension and pulmonary hemorrhage, especially when that LV just doesn't look like it can cope with any more volume and you're getting back pressure. I said PJ difficult to measure. I think what I meant was we had maybe differences in how we assess the ductal size, and it really doesn't matter. We've now got an Iowa score that's very, very high. We've got 13. I looked to measure SVR because, do you think, is this LV struggling because the systemic vascular resistance has been high? But I think when you get a duct there, you just can't make head nor tail of that particularly. So we agreed a plan to optimize the hemoglobin, transfuse that more, and the hemoglobin had sagged a bit, to continuous dobutamine, and which was at 5, and we left it at that, to consider some morphine. The BP was still, I worried, when I'm saying I couldn't really calculate that SVR, and there was runoff, so by definition it's low. I still worry that that LV was working against a sort of increased systemic vascular resistance in some way. So if the babe, and I also just want to decrease any risk of agitation and making that pulmonary venous pressure worse. So consider morphine if the baby's at all agitated, and treat the duct. And that happened later on that day. Maternal milk was going in, and I haven't actually created any more slides because I haven't run out of time. There's lots we could talk about. But that baby's duct closed very nicely over the next few days, and the LV returned to normal by the end of the week. And she's had a lovely stable course since then, and full enteral feeds and lines out, and minimal ventilation. So I'm quite pleased with that, given her size and gestation. So I'm going to stop sharing so I can see you. No, I can't see you now. I'll stop sharing anyway.
Thanks, Anne Marie, for this lovely presentation and very interesting case. So just take questions from anyone.
So I just think, within the first 40 hours, we've gone from one pathophysiology to another quite dramatically. And yeah.
Can I just comment about that first line of inotrope? I know Zoltan actually raised the point that they tried dobutamine in the urine, and that didn't work. So I'm a bit concerned actually about dopamine, because I agree with Maha, it is not an inotropic support agent, it's more vasopressor agent. And the problem with dopamine, although in literature they say it's dose dependent, but it's not proved in preterm babies, and they might respond differently even on small doses. Obviously you try to avoid tachycardia, as you said, Zoltan, but the dopamine also in a pathophysiology where you have a very significant duct like this will drive more the systemic blood pressure, which will shunt more blood to the lungs. And that's why Anne Marie and Neil stopped dopamine and opted for dobutamine just to reduce the SVR a little bit, which will help to reduce the amount of shunting. So it would be really good to discuss it further, maybe in another meeting, and just see.
It would be good. It'd be good to hear more about what other people are doing. It's very difficult because once you get into that ductal steel phenotype, and that's what's driving your blood pressure going down, it's counterintuitive to give a vasodilator type drug, because you may well lose your cerebral perfusion or renal perfusion if you can't, maintain your driving pressure. But then if you push the SVR up, you just flood the lungs. So it is a really difficult balance. And I think that's why I'm increasingly in favour of these very vulnerable babies, of actually managing the duct before we go right down that pathway, because I think it's tricky. The other thing I think is that, we're hopefully going to increasingly use cerebral nerves in this, and it might just help us as we introduce different inotropes, think about, okay, is that helping us? The BP may do nothing or go up and down a bit, but being able to see what the impact is on organ perfusion might be the thing we need most. So I'm hoping that that might help us nuance treatments a bit as we go forward.
Yeah, I was actually about to ask if any other units are using NERS in the first few days for those babies, because I think it was quite useful in this case.
We are in the process of starting very soon. We have got the nurse, we have bought few of them, and we are going to trial it in next few months. So educators are working on it now.
That's great. Thanks, Vikash. Which one did you buy?
Is it because one of my colleague Santosh brought it? So he's is it Massimo or what? Forgot the name.
Yeah.
Massimo.
Mm-hmm. The root, yeah. That's great one actually.
Yeah, you got 3 of them actually.
Oh,
so you got, but we cannot roll it out. The educators till we are all nurses are trained on it. So we have used few times for on a transport. I think we're on a rig just as an experimental basis. But we are all getting trained soon. But Mahmood, I agree with your comment in terms of the use of dobutamine. So, but that's what we have the last few years of practice for transient circulation. That's the only inotrope I use, if at all I need. Particularly, it helps in decreasing SVR, and I've seen that timely use of, if at all we need to use, try and avoid completely. And if at all it, you don't really have to add any more inotropes. Most of the time, you get away without anything else, and that had a significant impact. The use of dopamine again is very, very I've hardly probably it is getting out of the use in our unit too.
And I'm interested in that, Vikash. So you've been very successful, by the sound of things, at introducing dobutamine and moving people away from dopamine. Do they tolerate blood pressure slightly lower than they might have, as long as perhaps the renal, the urine output's fine, the lactate's fine? Are you able to, or in fact, have you found that your blood pressures are okay?
So what we have done, Anne Marie, what we are moving towards is actually to tolerate a bit of getting used to and change in practice, particularly because from the nursing staff and junior doctors' point of view, they get really, really nervy, particularly as soon as they see mean blood pressure falling below the gestational age. This is trained into our mind. And we are, we still, despite of all the available evidences we have, that aggressive treatment of blood pressure is more harmful rather than this permissive blood pressure readings.
So is the multimodal assessments okay? If everything else is okay, you're managing to get people just to sit tight.
Teaching, but every once, as soon as my first induction teaching is this blood pressure management for them. So we towards them, and if you needing them, so we have settings where your urine output is falling, lactate is rising, then manage to use dobutamine, and the second inotropes we add is adrenaline.
Yeah. How what's your maximum dose with dobutamine typically? Do you avoid going over 10?
No, for dobutamine, I've gone up to, for dopamine, whenever we had used in the past, I've made it a ceiling in the not to use more than 10. Dobutamine, I've gone up to 20.
And you're not getting too tachycardic generally?
So not always, and even years more than, if you see it is having tachycardia, we reduce the dose of dobutamine.
Yeah. And if you add an adrenaline, I'm sorry, I'm picking your brain, but if you add an adrenaline, do you find you pull back the dobutamine a bit? Just to avoid that increase, yeah. I mean, I think that sounds like a nice combination. That's what we're sort of hoping to work to. So that's nice to hear. And I do think of people for our unit, which people, we're a big team, and it is difficult to get everyone thinking the same way about blood pressure. And of course, there are concerns if it's getting lower and lower. I do think having other markers of end-organ perfusion, like our nurse, which we're hopefully rolling out fairly soon. We're already using it, but we hadn't used it in our preterm population routinely, but we're moving to that. I'm hoping that will give people just that additional security and information that they might need. So we shall see.
Yeah, we usually use 2.5 to 5 of dobutamine, Anne Marie, and hardly go out more than 8 because of the effect of tachycardia.
I suggested going up to 20 to some of my colleagues recently, and they were horrified and worried about tachycardia. So it's interesting to hear your experience, Vikash. You've obviously probably used more of it more routinely. So
no, routinely we as I said, that we don't routinely use dopamine at high levels. We go, the average levels are around 5 to 10.
Okay.
But adding up if you are needing blood pressure drop, so what nurses do is they sometimes increase the dobutamine and then add adrenaline to pull back and then bring back the dobutamine.
Yeah, that sounds very reasonable. Yeah, that's useful to hear. Okay.
Maha?
Hi, I was just going to agree with Vikash. I think Vikash, you and I, what your group and our group do very similar. So for years we've been quite anxious with dopamine, and I used to always just kind of turn it off if people started it, because at the beginning of a baby's life. But so we just don't use it now in our little ones or in any baby that we're concerned about their cardiac function, really. We either will start with dobutamine, probably similar doses to the ones that you've said. We can go up sometimes to 20, but we don't tend to. About 10, 15-ish maybe is max. But adrenaline we're using much earlier, and just avoiding the dopamine. And I think more importantly than what agent we use is what I think, like everyone has said, is just to look at everything, not just the blood pressure. That is such a misleading number sometimes. It's just so easy because it's a number that is displayed in front of you the whole time, so you can just look at that and forget other things. But all the end organ perfusion, we'd love to have nearest back, but the lactate, the urine output, even the saturations of the baby, and eventually, even the renal functions, etc. But yeah, and their heart rate. So lots of things that we need to be monitoring regularly that maybe are slightly harder to look at than just the blood pressure number.
Yeah,
we should,
absolutely.
I think, all go away from, we should steer away from just aiming to get a blood pressure number that we're happy with, isn't it? Because it's the tissue perfusion we care about.
Yeah, no, absolutely. And I think that's just really important that we, I think we all will be agreed on that, but it is one of those continuous education points. One of the things that we've trying to introduce as to how people think about it is, just as well as the multimodal assessment is, what's making your mean blood pressure, what's your systolic, what's your diastolic, because again, that can give you useful information. I'm not sure I've entirely certain that it always helps, but it can be helpful, particularly if you've got an arterial line in situ.
Totally agree with the systolic and diastolic. I hate the mean.
It's just so misleading. Yeah. Yeah.
That's it. Thanks.
So, anyone else? I hope that was okay. It was just a quick gallop through the images because I've not had much time and haven't looked at them recently.
No, that was brilliant. That was brilliant. Thank you so much.
Okay. Right. Okay. I think we'll maybe round up there. But that's been very helpful, actually, hearing everyone else's thoughts on blood pressure management in these small preterm infants. It aligns very nicely with some work we're doing just now, just in terms of our unit and network guidance.
Thank you, Anne Marie.
Thank you.
Excellent. Thank you, everyone. Thanks.
Thank you. Bye.
Thank you.
Thank you.